Okay, so good morning, wherever you are in the world, good evening, and welcome to this neurology virtual morning report. I'm Sebastian. I'm a neurology resident in my final year and chief resident of neurology at UCLA, and I'm going into neurophysiology as my fellowship next year and looking eventually for a neurohospitalist, academic role. And really just reiterating that this virtual morning report is a very safe space for us all to learn together and put our heads together and learn from each other and solve zebra cases, but also the bread and butter cases and share our enthusiasm for learning medicine and especially for learning neurology. I've introduced myself, but I might now just go around and let the others introduce themselves. Maybe Vale, do you want to start by telling us about yourself?
For sure. Hi, everyone. Really excited to be back with another Neuro VMR. I'm Vale. I'm calling from Lima, Peru. I'm an IMG applying this cycle for neurology. I'm really happy to discuss this case. And now I can pass the mic to Jeffrey, who is our guest presenter.
Hey everyone, I'm Jeffrey. I'm one of the rheumatologists here at Duke. Very excited to be here. Thanks for inviting me, Vale, to present this case.
For sure. Thank you so much for coming in with the case. And nothing on VMR would be possible without, the people in the background behind the scenes. So I'll pass the mic to Kritika and Simi, who are doing teaching points and scribing so that they can introduce themselves.
Hello everyone, I'm Kritika. I'm from Bangalore, India. Very happy to be part of this presentation today.
Hello everyone, very excited for Jeffrey's case. They're always very fascinating and discussion by Valley and Sebastian. Looking forward to the session.
Okay. Well, I think those are probably our main clinical problem solvers members to introduce themselves. I know I see a few familiar faces in the audience too. So Jeffrey's going to be presenting the case, and I think Vale is going to be discussing. I'll be co-discussing and facilitating. So maybe if we're all set, Jeffrey, do you want to take us away and give us maybe just the chief complaint or the presenting complaint?
All right. So you want me to just tell you the chief complaint, or you want me to go through like the HPI as well? What do you prefer?
I think for now we'll just start with the chief complaint.
All
And
right.
very quickly just think about how to approach it, and then of course we'll hear more on the HPI.
Okay. So the chief complaint is headache along with painful blurry vision.
Okay. So Vale, what comes to mind when you hear headache and painful blurry vision?
Yeah, thank you, Jeffrey. I think I will start with the headache part. When it comes to headache, we often think about like primary versus secondary headache. Usually, to differentiate the two, we need to look for red flags. So in this case, we have a red flag, the painful blurry vision, which I think it's a localizing neurological symptom. But we have I often remind myself to kind of to take a step back and also have like the anatomical approach before like the two primary or secondary buckets. And the anatomical approach is usually, things that are inside the head, like the brain and the meninges and the vessels. And then also things that are outside the head, which also include the vessels, for example, the temporal artery in GCA, and also things that can cause headache that are not necessarily neurological per se, like for example, things in the neck or in the ear, or in this case, it could also be like eye pain that is, presented with another, like retroocular headache, for example. With that with that said, then I would also like to, point out painful blurry vision. It's for sure a red flag that makes me think that this is less likely something like a migraine or a tension headache or like a trigeminal neuralgia, a spectrum type of headache, even though you can have some retroocular pain with some trigeminal neuralgias and some cluster headaches. For that, I would like to know if there's some like autonomic signs, what is the gender and the age of the patient, the time course. But honestly, I first worry about secondary causes of headache that come with painful blurry vision that can be emergencies, such as, for example, ophthalmological things first, like a glaucoma or like a cellulitis, that at this point would be like a orbital cellulitis that would be very scary. Um, Also, going a little bit back could also be like a painful, blurry vision, maybe an optic neuropathy type of picture with a pain. Often think about optic neuritis. And emergencies in that case would be inflammatory causes, but also like vascular causes, like ischemic optic neuropathies, are are a scary thing. Um, and yeah, so I think my next steps would probably be to expand on, time course is queen. Also, if the pain is worse with eye movements, to see maybe this is something affecting also the muscles. If there's maybe afferent defect, thinking about optic neuropathies, do the whole shebang. But I'm all over the place, I think, a little bit. So what do you think, Sebastian?
Yeah. I think that's, wonderful discussion, and I like the way that you've, focused on headache, and you thought about how you approach a headache and you explain the sort of primary, secondary, and certainly red flags. And then I think separately you alluded to the fact that, it sounds like there's headache pain, but separately there's pain with something about eye movements. And that really is consistent with or concerning for an optic neuritis, which has its own schema of kind of anterior and posterior causes, and there's all sorts of inflammatory, infiltrative, and infectious, and and metabolic and nutritional and genetic etiologies for that. And I think when I put the two presenting complaints together and form a Venn diagram, there's a couple of things in the middle, that I think you kind of alerted to that I'm concerned about in this case, and certainly we want to rule out. And for me, the top two things to rule out with headache and anything around any pain around the eye would be glaucoma, and then also a giant cell arteritis. But let's hear more of the history and update our discussion with that information.
All right, yeah, amazing discussion already, and I'm excited to share the rest of the story. So this is the story is like going to be split up into different sections, because essentially she presents initially as an outpatient, and then for that problem eventually gets admitted, and then it gets readmitted again. So the initial a complaint that she had outpatient was, so she's an 81-year-old woman, and she's had about 4 to 6 weeks of a new onset constant right-sided headache that she described as intermittent pain. It was behind the right eye, close to her forehead area, also next to her right temple. And that was associated with intermittent blurry vision, which she said was worse in her right eye, but maybe also affected her left eye. And then also on the right side, she had pain with eye movement, especially with rightward gaze. She also, when the pain was really bad with the headache, she would have tearing, and sometimes she would notice double vision or diplopia horizontally. She also noticed that on the left eye, there may have been some blurry vision, but there was also some eye pain on movement. And then pertinent review systems. So she, in addition, has been experiencing fatigue, joint pain, especially in her shoulders bilaterally and her hands bilaterally. She says that she has also these new sleep issues. She has to wake up every single hour each night to go urinate, and wonder if that's contributing to her fatigue. And then pertinent negatives, she denies any discharge from her eyes, no floaters, flashes, no complete loss of vision or no curtain descending over the vision. She denies any paresthesias, weakness, no sensitivity to light or sound or nausea or vomiting, and describes there's no antecedent trigger to the headache. So there's no trauma, injury recently, no fever, and no other illness. And for this headache, she was just started 2 weeks ago by neurology on etodolac with minimal improvement.
Okay.
Wow, certainly a lot there. Vale, do you want to start by, sharing your thoughts?
Yeah, for sure. We have a lot of interesting information. We have the age, which is, an elderly patient. We also have the time course, which is more like a subacute to maybe chronic time course with an intermittent kind of progression. I think we didn't really talk about the red flags of headache, and I think the HPI has a bunch of them. So, people remember this mnemonic, the stands for like systemic signs such as fever, but here we also have joint pain, fatigue, and sleep issues. The sleep issues particularly made me think about some things that probably we can discuss later. But that's for sure signs that, it's nothing that may be primary neurological, but rather, something systemic maybe causing the headache, which is often the case. Headache can be very inspecific. Then we also have, the focal neurological signs, which is the N on the Snoop mnemonic, such as the fact that there's blurry vision, that's intermittent. There's some eye tearing, like some autonomic signs, and then we have diplopia. And then we have eye pain, of course, which is with eye movements, especially to the rightward gaze, which paired with a diplopia make me think that something on the extraocular muscles may be part of the headache and the eye pain, like that might be the cause of the pain. So I'd be worried on that. And I think at this point, I'll put the headache aside, like the headache schema aside, and focus on the diplopia schema. And we often think about diplopia as, the extraocular muscles being misaligned, so they are not like completely coordinated as they should be, and they could imply something in the eye like a refractory problem, but we're not contemplating that right now, which will be ophthalmological thing that ophthalmologists, that will be like the problem of the ophthalmology people. But for us, we should think about binocular diplopia, which I'm assuming is the one in this case. We would have to cover the eye to see if that's the case. If it goes away with covering the eye, then we will say it's binocular diplopia. And we should think, is something going on in the muscles itself, like on like the lateral rectus, the medial rectus, the superior oblique, the inferior oblique. And then we think, like, for example, things in the muscle could include like thyroid disease, like make the muscle really big, or some like deposition disease or like infiltrative disease that can also make the muscle really bulky. Then I will go to the neuromuscular junction, like things like fatigability, thinking about myasthenia, especially with intermittent nature of the pain, thinking if, this is worse at the end of the day or something like that. Then I will think of the nerves, so like the third, fourth, and sixth. And given that this is worse with rightward gaze, I would like to know if it's, worse with lateral or medial gaze, and especially like, is it when you're looking to the left? Is it when you're looking to the right? That's kind of another schema that we can activate, which is horizontal diplopia, which is, focused on the sixth and the third nerve, but also in like the horizontal eye movement centers, going a little bit further. We have to also think about, the cavernous sinus, where all the nerves are kind of there, and going to the brainstem, where usually, we have to focus on the midbrain, but also especially on the pons, if there's something there. And, when it comes to like conjugate horizontal gaze, we usually think about the MLF or and also the PRF, something like that, which is like, part of all those centers in the midbrain that, I'm sorry, and the pons in midbrain that would lead to something like this. And yeah, and I'll end my part. Sorry, Sebastian, before you say something, I'll end just saying that this time course, of course, going back to the equation that we always talk about, makes me think that maybe could be something inflammatory, like intermittent, going on. That I'll put my card on that. Go ahead. Tell me what you think.
No, that's a lovely discussion. I love how you run through the etiologies based on anatomic distribution, and I like what you were saying at the end. I think we're often taught in neurology to utilize two key features to really help narrow down our diagnostic bucket, and one of those is time course, as you said, and I agree with you that the sort of 4 to 6 weeks raises concern for some sort of inflammatory, infectious, metabolic or nutritional etiology, maybe malignant. And then the second part, in addition to the timing of the the history, is localization. And there are a few things here that I think you mentioned it already, that we can localize. I think we're concerned about the optic nerve, second cranial nerve, being involved. Given the double vision, we're worried about the extraocular muscles and their innervation, especially pain with lateral eye movement on the right, concerning for cranial nerve 6. And when you start invoking multiple cranial neuropathies, especially as Jeffrey was saying, if there's potential left-sided etiology, then we're pretty worried about something that is systemic and maybe infiltrating. Is this something that's infiltrating along the skull base, going to cause multiple cranial neuropathies or affecting the meninges? Is this something that's infiltrating more locally? So I think, we do have some nice clues. And just finally, I love that you were talking about headache red flags. And I think I'm very surprised to hear the neurologist saw them and discharged them on a non-steroidal anti-inflammatory. I'd like to know more about what they were thinking and, what sort of workup they had planned. But there are multiple red flags here, as you alluded to. And, for me, anyone with a headache over 50, I would probably get some neuroimaging. Anyone with constant head pain, that's concerning. And obviously, as you mentioned, anyone with any focal neurologic deficits, very concerning. So I think we'll maybe move on and hear a little bit more from the rest of the history. But love the discussion, Vale, and it sounds like we're on the same page in terms of starting to narrow down that differential. In fact, there's one more thing I'm going to throw back at you. And what 3 things would you love to see on this exam that would help you rule in or rule out some of the differentials that we discussed? So what are you most interested to see in this patient's exam? I know we'll hear a little bit more history first, but what would you want to see the most? If you could choose 3 things.
Wow, 3 things. I would love to see eye movements, like to confirm what nerve or muscle is involved. Then probably what else? Maybe the pupils. And then I would like to see, well, I don't know if you consider like eye exam as one thing, but maybe also what else? Honestly, like cranial nerve exam would probably be the most thing, because if it's just like multiple cranial neuropathies, like something that you alluded to, going out from the nuclei that they are born in, I probably expect some other cranial nerves to be affected as well. So I would like to rule those things out.
Oh yeah, I agree. I think if there are 3 things I could choose to look at in the exam in this case, really help me localize. So actually, my number 1 would be eye movements. I agree with you. I think the second thing would be other cranial nerves. Is this like an infiltrated multiple cranial neuropathy? The third thing for me that I would critically want in this case is a fundoscopic exam. And neurologists, should be doing that. Often we rely on our ophthalmology colleagues, but in this case, I'd be very interested to see if there's optic disc edema. And optic disc edema is concerning for inflammation of the optic nerve anteriorly. Now, you often hear the term papilledema, but actually that specifically refers to optic disc edema due to raised intracranial pressure. Now, the patient could still have optic neuritis without having optic disc edema, and that would just suggest that the inflammation of the optic nerve is more posterior and less anterior. So again, I think that those are the things that I'm thinking about, wanting to see on my exam. But thank you, Vale. That was great, and I agree with you. I think for me, there's the highest yield parts of the exam. So Jeffrey, let's hear more about the rest of the history.
Okay, awesome. Yeah, amazing discussion so far. So, and then just to clarify, I believe, when neurology, so this patient is outpatients. They're not admitted yet, but neurology's plan was to actually get brain imaging, which was done. And then this next aliquot is going to be about the history. So they have a past medical history of psoriasis and rheumatoid versus psoriatic arthritis, and they're on immunosuppression for that on secukinumab, which is an IL-17 inhibitor. They also have a history of heart failure, secondary to coronary artery disease with mitral valve stenosis, status post a bioprosthetic valve replacement on warfarin, as well as atrial fibrillation, COPD, hyperlipidemia, and type 2 diabetes, for which she is on medications, oral medications for diabetes, hyperlipidemia, and on diuretics and hypertension control medications for her heart disease, which have been recently increased because of edema in her feet. And her past surgical history is only notable for the bioprosthetic valve and the mitral valve. Family history is notable for breast and colon cancer in her multiple family members, brother, sister, and aunt. And social history is notable for a 147 pack year history of smoking, but she quit 16 years ago. She denies any alcohol or drug use, Otherwise was at home, was retired, no exposures that are unusual, no travel history. And that's her histories.
Wow. Okay, Vale. How has the rest of the history updated or informed your impression so far?
Yeah, I mean, I will probably congratulate the patient for quitting. You know,
Yeah.
it's been a while, so that's good. I think, I mean, there's a lot of past medical history. For sure, the psoriasis, rheumatoid arthritis, Jeff representing the case, I'm for sure biased, that this could be something like systemic inflammatory going on. But I think also, very heavy, like heart problem burden make me think, about could this be something embolic going on or something like embolic infectious, like, well, with the time course, maybe less likely, but with AFib and, a valve there, I probably will be worried about maybe, um, well, I mean, now that I'm thinking about it, maybe not so much, because if it's 4 to 6 weeks and intermittent nature, what are the odds that a thrombi is getting there every once in a while? The breast and colon cancer history, it's interesting. I don't know if at this age I'll put a lot of money on that, being the cause, just like a genetic thing going on. Um, I think the past medical history, the thing that is most like worrisome for me is the psoriasis and rheumatoid arthritis part of it, involving now the brain in some way, like through the meninges, as we talked about, but also through the vessels, maybe causing something inflammatory, intermittent that is could explain her symptoms. What do you think, Sebastian?
Yeah, love it. I agree with you. I think, yes, the social history with, the smoking history and also the atrial fibrillation, we do start to think about, is this a, small vessel disease issue? Is this an occlusive thrombus or embolus, as you said? But given the time course and the very kind of predominant, history of um, systemic features, I think that is kind of lower down on my differential. Of bigger concern, I think really, is the psoriasis and rheumatoid arthritis, but also the immunosuppression, because we talked about how primary inflammatory etiologies are on the differential, but so are infectious. And in a patient who's on immunosuppression, I'd worry about opportunistic infections. And there's a long list of infections that can infiltrate the optic nerve, and including toxoplasmosis, syphilis comes to mind, some viral etiologies, and so that's also there, and I'd be concerned for those. But other than that, I agree. I'm kind of ruling, really leaning towards this being systemic inflammatory process, but also considering infectious. And so, with that said, is there anything else you want to know before we move on to the exam, Vale?
No, I think that's such a great point that you made. I would also add maybe like TB on that
Yep,
infectious optic neuritis bucket,
yep,
to not forget.
definitely.
But yeah, I think we're ready for more, Jeffrey.
Okay, all right. So I'm going to introduce the physical exam, and part of this is our exam from the rheumatology standpoint. Part of it is from the neurologist's outpatient exam. So on an admission, she has a fever of 100.8, and she has a little bit of low blood pressure, 100/60, tachycardic to 110, otherwise standing well with a normal respiratory rate. Systemically, she has inflammatory arthritis essentially in bilateral hands and shoulders. Otherwise, no other things remarkable. No lymphadenopathy, no neck stiffness, no rash. Neurologically, essentially her exam is quite normal. So mental status, she's alert oriented, affect is normal. Memory, language, and fund of knowledge was within normal limit. Cranial nerves with full visual fields, no ptosis, no nystagmus. Her extraocular movements were full and had smooth movements, no abnormal saccades. And pupils were equal and reactive to the light. There was no facial weakness or sensory deficit. Her tongue was midline and there was no atrophy. Motor exam showed normal bulk and tone, no arm drift, and no tremors or fasciculations. The strength was 5 out of 5 throughout. Sensation was intact to light touch throughout without any abnormalities. The coordination was intact bilaterally for finger to nose exam, and then her finger taps and arm rolling were intact and equal bilaterally. Interestingly, her gait was narrow-based, but she had narrow-based tandem walking without assistance, and that is her physical exam.
Thank you, Jeffrey. By any chance, on the eye exam,
Yes. I can add the eye exam here too. So ophthalmology was eventually consulted, and their initial eye exam showed essentially the only abnormal finding was that on the right side, there was cotton wool spots. That was it. No papilledema.
And did we check the intraocular pressure too?
I believe the intraocular pressure was normal bilaterally.
Because glaucoma was raised as a very important thing for us to be excluding as a neurologist in this setting. And you may have mentioned this, Jeffrey, but did she have any tenderness of the temporal arteries?
She did not. No tenderness to the temporal arteries or to the scalp.
Okay, so Vale, what do you think?
Yeah, this is really helpful. I mean, we are not seeing the diplopia in action, I believe, on this one, but I think it's really helpful to rule out some things that we were talking about. For example, optic neuropathy. I often think about like four classic things we should look for. First is, visual fields. Usually optic neuropathy can cause visual deficits, but they are on the center of the visual field. So they may be missed on like finger, visual field assessment. So usually, there's some other things that make you think of that. You should do like more advanced ophthalmological testing. But then also looking for like afferent pupillary defect, which seems like was not the case. It's another thing that we should look for. As Sebastian mentioned, if there's disc edema or not, that would make us, or is this as if there's also like signs of disc atrophy, that would make us think of like a chronic ongoing optic neuropathy, which are all things that are not going on here. We do some things that make us, with all the heavy past medical history, the cotton wool spots maybe from like the small vessel disease type of thing. I'm very worried that this patient has, well, I thought it was 108, but it's 108.8. I'm not sure what that translates to Celsius, but I understand she's a little feverish. So that's a worrisome thing. When it comes to like fever plus headache plus some eye things, I think meningitis is one of the things that we don't want to miss. With this time course, we would be on the inflammatory cause, on the chronic to subacute causes like infectious, as we mentioned, like TB, fungi, but also inflammatory systemic things like rheumatologic and malignancy as well. What else? I also wanted to mention, because we didn't talk about it in the HPI, but the fact that she had sleep issues was another thing that makes me think often of like the hypothalamus, or like, well, not like, more like posterior fossa, or like that has like a localization value to me. Jeffrey, do you have information about like why did she have sleep issues? Like, did she have night terrors, or like she was sleepwalking or something like that?
So she said that she basically had to wake up multiple times at night to pee, but also her diuretics were increased for what was thought to be heart failure, causing her to have increased swelling in her extremities.
Yeah. So, but reassuringly, something we sort of glossed over slightly in the history when we were discussing it, Vale, but as you mentioned, there's sort of frequent urination in the night, and reassuringly, the abdominal exam is normal. So could be thinking about drug side effect or something neurological, which we can circle back to. And so Vale, you mentioned meningitis, and just for sort of for teaching purposes. So, what additional tests would you do, or what specific things would you want to document in your exam to help you rule in or rule out meningitic processes?
Yeah, I'll probably do like the classic neck stiffness, then Brudzinski, Kernick, which are signs that are very historic, but I think like they have like 50% sensitivity, which is not the best at all. Otherwise, I mean, uh, fundoscopy can also give us some signs of like increasing the cranial pressure because of the inflammation. But otherwise, I would like to learn from you, Sebastian.
Yeah, so I agree. If I see a patient, I'm worried about sort of meningitis. Classically, to check briefly for photophobia. They're covering their eyes, they got their eyes closed in the room. Can they tolerate the light of the clinic room, which usually is pretty bright? And then, just quickly check for, meningitis or any neck rigidity, and I will just rotate the head sort of loosely on the neck and feel for any resistance. But there are a few specific signs. You mentioned Koenig and Brzezinski. There's also the jolt accentuation test that I was taught as an intern, where you shake the patient's head. I think it's about 2 or 3 times a second, and see if they can tolerate it. And my understanding is that it's a pretty sensitive test for meningeal irritation. So I think that would be another nice one to add. And then the final part is, if I'm worried about bacterial meningitis, I'd look for any skin rashes. Again, it was non-blanching, concerning for kind of meningococcal process. Okay, but great. And finally, obviously fever, and 100.8 is a low grade fever. Anything above 100.4 we worry about. So again, raises our concern for inflammatory and infectious issues. So let's move on to think about what we would want to send. Let's say you're the neurologist right now, you're in the emergency room, you've seen this patient. What would you want to send? Maybe let's start with some blood tests that we'd send, and then we can move on to discussing whether we'd want CSF, and then think about neuroimaging. So what blood tests would you be interested to see, and why?
Yeah, with the suspicion that we have about meningitis, I mean, it would be less likely, but I'll still go for like blood cultures, just to be safe. Then like basic CBC, metabolic panel, with the diuretics. We should not forget about like maybe something going on there. What else? I don't know if inflammatory markers will be really helpful in this case. I think, we have the other signs that this is quite inflammatory. Um, should I go with like CSF studies and imaging, or do you want to comment on that before?
I think maybe we'll just start with labs. When I was in training, I learned a nice mnemonic to make sure that I'm being very systematic when I work through what investigations I want to send in a patient. I don't forget it. And it was UBERS. The U was urine, the B was blood, the E was ECG, the R was radiology, and the S was special testing. And sometimes I do like to work through that. I've skipped U, even though we probably should send some urine tests, especially with the the frequent urination. But thinking about blood tests, so I agree with blood cultures. I think it's important to send that to anyone presenting with a fever. I would send inflammatory markers. I would send a sedimentation rate and a CRP. It would be good to know sometimes in these patients, you can see what the trend for them is like of the inflammatory markers in clinic, and you can see how it's changed. This is a patient with rheumatoid arthritis. I'm sure they've had their SED rate and CRP checked several times. So it'd be interesting to see if it was like mildly elevated, not that interested, but if it's very elevated, it would be nice to compare that to prior levels. And then other lab tests I would consider sending, would include any, so like syphilis. We talked about infectious kind of workup. I would send, RPR. I think somebody mentioned, I think Bartonella, and I think we can send a lab for that. I'd have to maybe defer to my ID colleagues. I think we can send a lab for that in blood. TB, I'd send a Quant Gold. We mentioned that's on the differential here. And then if they haven't already had some of the autoimmune, the antibodies done for rheumatoid arthritis and psoriatic, then I would consider sending those. I think my suspicion here is quite high, and that could include sort of double-stranded DNA, anti-Smith, but long list of rheumatoid factor. It's a long list otherwise of autoimmune. So I think, yeah, working through, we've talked about infectious labs, so we've talked about some autoimmune labs. We've talked about hematology panel. And chemistry panel, you mentioned, getting some basic electrolytes and, okay. So I think that's a nice discussion for blood test that we would send. So the next one's ECG. Oh, and someone's mentioned thyroid. I like that. I think that's a great suggestion, especially with the the ocular symptoms. Thyroid eye disease definitely can cause headache, painful eye movement. So thank you for bringing that up. That was Mattia. So moving on to ECG, we'll skip maybe on the Ubers. We could do it, but radiology we skip. Maybe let's just talk about CSF for now. Would you send CSF in this patient, Vale, and why?
Yeah, for sure.
Okay.
I would for sure do the CSF studies. I would like the basic things, the cells, the protein, the glucose, but
Mhm.
also more advanced things. I love they mentioned syphilis,
Mhm.
some cultures, some maybe a gene expert to rule out TB, some cytology, maybe some I'm losing my brain of I don't know if CSF you can do I'm not, but to see specifically what type of T cells are there to see if there's anything um like flow cytometry. um what else? Maybe some fungi, we could do antigen, urine antigen also for histo, just to rule that out. I love the idea of thyroid disease. Patient has tachycardia, has pain with eye movements, but I think imaging probably would be more helpful for that, and some lab work. On the CSF, what else? What else? No, I don't think I have.
No, I think that's a great workup so far, and I agree that we are considering getting basic cell count chemistry as you mentioned. Certainly we get cultures and gram stain, and that includes sort of AFB fungal cultures. And think about infectious etiologies. You mentioned the VDRL. Agree with that. And then we talked about doing sort of AFB and fungal stains. I would send a meningoencephalitis PCR panel. Viral etiologies can certainly cause it. And viruses can also cause secondary vasculitic processes, especially VZV. So that would be helpful to know. And then we obviously we've invoked meningitis. So with that, we want to exclude bacterial etiologies. And then we mentioned also sending some specific pathogens that can cause optic neuritis. And we've sort of gone through syphilis and Bartonella, and I think that there's a toxoplasmosis CSF antigen you can send, so we'd probably want to send that. Lyme, I would throw in there. I'd do Lyme antibody panel, and then so that's kind of we talked about infectious, and then I think malignant. I agree. I mentioned earlier anyone on immunosuppression worried about some kind of infiltrative neurologic issue. I definitely would want to do cytology and flow cytometry to consider if this is a hematologic malignant process. Okay, so I think that's a great workup so far. And then imaging. Would you want imaging, and what would you image?
Yeah, for sure. I meant to say the crypto urine antigen. Sorry, I said histo. Um, yeah, for sure. I think I'll probably go for an MRI right away, with contrast to see if there's signs of, inflammation, or the barrier is compromised. I'll be interested to see if there's anything in the midbrain or in the brainstem
Mhm.
lighting up, or if there's meningeal enhancement as well.
Yeah, absolutely. Love that. I agree with you. I think I'd be getting an MRI of the brain with and without contrast. Would you get vessel imaging, Vale?
That's such a great question. I'm not sure. Now that you mention other types of imaging, I'll get orbital imaging as well, with fat suppression and contrast also, because
Mhm.
we have to rule out those cavernous
Mhm.
things going on in the orbit as well, like if there's signs of optic neuritis. Um, Maybe I would like to say yes, if
Okay,
there's
yeah.
vasculitis. I mean, yeah, I'm not sure if right away, but it probably be my next step if nothing shows up on the normal MRI.
Yeah, I agree. I would do brain, I would do orbits, I would do vessels actually. I think we've mentioned that vasculitis in the differential and other kind of vascular etiologies. So you can see vessel wall enhancement on MRI in certain protocols. So I probably would do all of those. And I agree with you about getting MRI orbits to look for any optic neuritis that, again, we didn't appreciate on our exam, right? Because we didn't see any optic disc edema. So we're thinking if they're, but the patient's got a pretty good story for some optic neuritis with painful eye movements and, blurring of the vision. So I'd be very interested to see if there's posterior optic neuritis that we couldn't appreciate on our exam. So agree with you. And then the MRI orbits will also tell us about other infiltrative processes around the eye, including any other kind of compressive inflammatory etiologies. So love that. Okay. So Jeffrey, we've talked a lot about what we would want to send. What information do we get back from you?
Do you want me to go through the labs and imaging together, or is it?
I think let's start with the labs, and then we can briefly kind of discuss, and then yeah.
Okay, sounds good. So the labs, I'm just gonna briefly describe the abnormal labs. So CBC, just abnormal for leukocytosis to 14, and the CMP, so that's like all the electrolytes, renal and liver function, only showed a hypokalemia to 3.0 and a small AKI creatinine of 1.3. Otherwise, everything else was normal there. Inflammatory markers sent, ESR was elevated to 68. CRP was elevated to 1.5, and the cutoff here is 1. It's mg per deciliter. So both elevated. She had blood cultures, HIV, quant TB, hepatitis B and C, Bartonella serologies, and antibody testing for syphilis, which were all negative. She had, from a rheumatology standpoint, RF, rheumatoid factor, anti-CCP, ANCA, which were negative. IgG4 levels were normal, and thyroid function studies were normal. She had 2 procedures done that came back with labs. One is a shoulder aspiration because of inflammatory shoulder arthritis that showed 29,000 white blood cells, no crystals, and bacterial culture was negative there. She also had, the second one was a lumbar puncture, and that showed 19 red blood cells, 2 white blood cells, normal protein, normal glucose. They did further testing with a PCR for viral meningitis panel, and that was negative. They did a cryptococcus antigen, which was negative on the LP, as well as a VDRL in the CSF, which was negative. And then the blood, AFP, and fungal cultures from the CSF were negative. And those are the labs.
Okay, so Vale, has this changed your your leading diagnostic suspicions, or do you want more information?
Yeah, I mean, I mean, there's for sure inflammation going on here, and I was surprised with the shoulder aspiration. I think, it's something that we did not discuss, but I mean, it is Neuro VMR, so I guess. But yeah, it's an inflammatory arthritis going on. Makes me think that maybe this could be a flare of her underlying rheumatoid arthritis or psoriasis, like if she had psoriatic arthritis. We have a little bit of an underwhelming LP. Seems that maybe could cause a little bit traumatic with those high RBCs, but we don't see really like signs of active inflammation, at least on the CSF right now, like no high protein, no high WBCs, normal glucose, and normal like basic infectious panel. I think, I mean, it's reassuring because we are not like dealing with a neurological emergency, like in the form of like bacterial meningitis, for example, but we for sure have to think about other inflammatory causes that may have a bland CSF, such as, those like systemic inflammatory things, but also things that do not get to the CSF because they're contained in the vessels. So I think, vasculopathy and like secondary vasculitis are things that we should consider like as complications of her underlying rheumatology diseases, or as new things that may be coming up. I mean, we rule out syphilis, so like that's another cause of vasculitis, but and also like viral, you mentioned VCV, which is another thing that could cause vasculopathy. So yeah, maybe I think for next steps, the imaging, but also like expand a little bit more like the antibodies on the CSF, to see if maybe we have answers from there. What do you think?
Okay, I like that. I agree there's something inflammatory going on, the white cell. I'm actually not super excited even about the, well, the SED rate's slightly high, but I think I was maybe expecting in the CRP something maybe even, more exciting, but it's elevated. Again, I'm reassured that I don't think this is necessarily a typical infectious process, could still be an atypical infectious process, but, I'm kind of reassured that we're not missing like a barn door bacterial meningitis, that the viral meningitis palsy is normal. That's reassuring to me. Okay, yeah, no, I agree with that. And then the shoulder aspirate, I mean, yeah, the white cells clearly inflammatory, reassure the bacterial cult is negative, again, thinking about something inflammatory, systemic. So Jeffrey, you want to share with us what the imaging showed, and reassure ourselves that neurologic history does usually manifest with objective changes on MRI, and we can usually localize something.
All right, yeah. So she got a lot of imaging done. So this is the imaging that actually got her admitted. So she first got an MRI orbits, which was the plan for the outpatient neurologist coming to her headache and the eye symptoms. And that showed a stable aneurysm of the right ICA that had been, I guess, there previously. And then a stenosis of the ICA at the supraclinoid segment, more on the left than the right. And then enhancement of bilateral supraclinoid ICA segments. And this was followed by MRA, head with angiogram. And this showed moderate to severe stenosis of the bilateral cavernous and supraclinoid internal carotid arteries with vascular thickening and enhancement, which then was followed by a CTA, chest, abdomen, pelvis, given the concern for a systemic vasculitis. And that showed no evidence of active vasculitis, but it did show there was some calcified and non-calcified plaques in the aortic arch, as well as some of the branches, as well as a little bit of dilation of the juxtarenal abdominal aorta. So basically a aneurysm there in that abdominal aorta. And then some other multifocal mild arterial stenoses of the aortic branches. And those were the images that were done.
Very interesting. Yeah, yeah, this is very much like, I mean, I'm not surprised. This is a Jeffrey's case. This is very interesting. I think we see signs of like vasculopathy very much like focal to the cavernous segment of like the ICA. Yeah, I mean, it's a cause of like secondary headache. I mean, back at the AAN, A presented a case for us of like diplopia and headache secondary to AP fistula of the ICA. So that will be right on there. But also we have some enhancement of the lateral supraclinoid segments, which made me think about like maybe something inflammatory going on there, very focal. I'm not quite sure how to match it with systemic findings on imaging, because it seems like they're more like secondary to her maybe like cardiac and atherosclerotic burden before, even though the aneurysms, I don't know, it would fit that. Well, maybe it does, like chronic high pressures. Then, so yeah, I think for next steps to consider, I probably consider sending some like autoimmune panel on the CSF for vasculopathy or like inflammatory diseases that affect the CSF, like Sjogren's. Well, we have some already, like we had Anna and Anka and all of those. So not those, but maybe Sjogren's and what else? I'm not really sure. But I'll put my bucket on ruling out first, like secondary vasculopathy causes at this point. What do you think, Sebastian, please?
Great, Vale. No, I love that. I agree with you that, this is, the imaging is very supportive of vasculitic etiology. It does explain the history with the headache and the orbital pain, and so that's reassuring. And that when I hear the term vasculitis, especially vasculitis affecting the central nervous system. You know, we kind of hear the term like, oh, primary angina is the CNS, you know, PACNS is invoked all the time. But there are also a lot of secondary causes of vasculitis within the central nervous system. And you mentioned a lot of the secondary etiologies that we'd want to rule out. I mean, I think about it being secondary to infectious etiologies that, you know, a lot of the, which we mentioned, especially sort of VZVs, bacterial causes, and then secondary to autoimmune processes, the systemic. And, you know, that can include, as you mentioned, sort of rheumatoid, Sjogren's. And so, you know, I think we've sent a lot of appropriate lab panels for that. And yeah, and again, the fact that it's not systemic, you know, is for me, it's unfortunate because in these cases, I always think about trying to get biopsies. You know, that's sort of the, you know, where I want to lean. You know, where the patient's got vasculitis. You know, I know the rheumatologists are going to say we want tissue, you know, before we're gonna know how best to treat. So it's a shame that we don't have any other targets per se, you know, outside of the central nervous system that we could biopsy and potentially, you know, and help triage and treat. But I think it's certainly where I'm leaning at this point. I agree with you. You know, you can try and get temporal artery, you know, ultrasound, see if there's a halo sign, and see if, you know, we can biopsy that. And you know, sometimes rheumatologists will like us to do that. But I agree. That's where I'm headed. And I think the last thing I'd say is, you know, I wouldn't forget malignant causes of vasculopathy too. You know, I've seen lymphoma cause vasculopathy, and you know, this is an 81-year-old woman. You know, so that's still in a differential, I think. And again, you know, that's why following up that CSF cytology and flow cytometry would be helpful. So Vale, here's a question for you. You know, I think in these sessions we spend a lot of time pontificating on diagnosis, but it's not how the real world works. You know, Jeffrey gave us the TB results straight away. You know, we got the, you know, what is it, the anchor straight away. So, you know, I guess my question for you is, what would you have done for this patient while you were waiting for all these things to come back?
Yeah, I guess the question is also like, would I have given this patient steroids? Probably. Honestly, I think I probably would have given this patient steroids. Just because there's like so many signs of like inflammation, and especially at the beginning, given that she had like blurry vision and headache and everything, that's a scary possibility of like sequelae.
Yeah. No, you know, I was always taught if you have concern for GCA, you should treat empirically. You know, don't wait till they've lost their vision to start steroid. You know, but of course the difficulty is you start steroid, you might lose your diagnostic yield and biopsy. Or, you know, not just for inflammatory causes, but also malignant causes of vasculitis, maybe even infectious causes of vasculitis. So I think for me, I think very carefully about the patient's history, the exam, what I thought my clinical concern was for, you know, for visual loss. And I think honestly, you know, I even would have considered with the fever starting empiric CNS antimicrobial coverage until the CSF resulted. I think that's probably something I would have done. Okay, brilliant. And so I think, Jeffrey, what we've got for you is we would consult the rheumatologist. I think would want some follow-up imaging. I think we mentioned sort of temporal artery ultrasound. I mentioned the MRI, you know, vessels with and without contrast. We have a black blood sequence that we don't do them a lot of centers, and you can see the sort of pattern of enhancement to give you clues in theory about the underlying cause of the vasculitis. But you know, depending on what center we're at, if we could request that. But I think that's where we're at right now. I think we've stopped our empiric CNS antimicrobials, and we're now debating immunosuppressive therapy, biopsy, further tests. So tell us what happened next.
Yeah, amazing. So I'm going to share with you the rest of the story until the very end, and then let you guess what you think the final diagnosis is. So what happened is this patient was, you know, just exactly as you said, consulted rheumatology. Initially, there was a discussion, should they be on bacterial meningitis coverage, consulted neurology, ophthalmology, and the strong feeling from the rheumatology was that this could be giant cell arteritis. So just as both of you mentioned, we started post-dose steroids on this patient. And actually, 2 days into that, she developed new altered mental status, which initially was thought maybe this was due to hyperglycemia because his glucose went up to 400, or it could be from steroid psychosis. So the steroids were dropped a little bit down to 50 milligrams of IV solumedrol. And then the glucose was treated with an insulin drip. She had some new perseveration and aphasia on the neurological exam done by the neurology team. An MRI was rechecked, which showed an acute infarct in the right globus pallidus, as well as worsening stenosis in the bilateral ICAs and a new stenosis in the left A1, which was thought to be concerning for worsening vasculitis, and a repeat MRA, but without contrast, unfortunately, because her kidney function declined, was done. And that showed new mild luminal narrowing of the distal P2 segments bilaterally, and redemonstrated the previous stenosis in the cavernous and supraclinoid segments of the bilateral internal carotid arteries, as well as the left A1 segment stenosis. And a temporal artery biopsy was performed after 4 days of steroids, and it showed transmural inflammation with nonspecific infiltrate consistent with giant cell arteritis. The Congo red staining was negative, so the patient was diagnosed with giant cell arteritis, started on tocilizumab, which is one of our main treatments for giant cell arteritis, discharged on prednisone and tocilizumab, but then a week later had an acute worsening of her neurological decline, where her daughter found her that morning and she was so altered she couldn't speak and she couldn't get out of a chair. So she was rushed to the ER, and the new MRI, and this is the last piece of information I'll give you, showed multiple new cerebral infarctions. This is done again a week after this hospitalization. So she's admitted, this is a new MRI brain, multiple new cerebral infarctions involving multiple vascular territories, including a large MCA infarct with associated cerebral edema and no hemorrhagic conversion, previous stenoses that are about the same, and new diffuse smooth pachymeningeal enhancement. And that is the final piece of information. I'll let you guys decide what you think.
Yeah, this is very interesting. Yeah, I think it's quite frustrating, to see this patient be so deteriorated. So yeah, I think we have like a GCA type of picture, but we also have this weird worsening that for me makes me think that this may not be, the full final diagnosis. Things that could worsen with high steroids and immunotherapy, I often think like about infections that we may be missing at this point. TB and fungi are the ones that come to mind, but also with a diffuse pachymeningeal enhancement that we're seeing right now, infiltrative diseases. With pachymeningeal things, we should think like sarcoid, which I'm not sure if it makes sense that it has worsened with the therapy, but that's something that maybe we could rule out. Then, well, infectious causes, I think we have a very complete workup. Maybe consider repeating those testings just to be sure. And then malignancy is another thing that I believe causes pachymeningeal enhancement. So yeah, checking those flow cytometry to see if there's something there. But otherwise, I'm really on the edge of my seat. So would love your help, Sebastian.
Yeah, lovely. I mean, I'm the cases I've seen of CNS vasculitis, the outcomes are pretty poor, pretty disappointing. Even if you made the diagnosis, often with immunosuppression, they don't really get much better, but they don't get worse like this. And the ones that I've seen, the classic case. So I'm wondering if there's a secondary cause that we're missing, not treating. I mean, considering drug induced, I don't know, a lot about you said they were on an IL-17. I don't know if it was tocilizumab or something else, is that a side effect of, is this drug induced, and the harder we're throwing, sort of, immunotherapy, the worse it's getting. As you mentioned, is this something that's infectious that we're not treating? Did we check for everything fungal, parasitic even? And then paraneoplastic, as you mentioned, might expect a temporary improvement, but, not treating the underlying etiology. So in this case, we want to know what the cytology and flow cytometry showed. I'd want to ask the rheumatologist if they consider switching to different immunotherapy. And then I'd reconsult ID to make sure that we're not missing an infectious, etiology and opportunistic infection. I think that's where I'm at right now.
Awesome. Awesome. Well, you guys basically got it. So this is a very challenging case, and we kind of went through in circles as well when we saw this patient. So essentially, we repeated some of the studies that we already done, including another temporal artery biopsy, another lumbar puncture, the MRA again. Everything was the same as before. So this is giant cell arteritis. So in a very small percentage of patients, giant cell arteritis can affect the intracranial arteries and cause CNS vasculitis. And I believe there's actually a very new recent paper in Journal of Rheumatology showing that it occurs in about like 10 to 15%, and it may be undetected. And with very high resolution MRI, you can see vasculitis of the dural arteries, and that's why you get pachymeningitis with it. Now, the interesting thing is these patients are often very, very refractory to therapy. As Sebastian said, it's very, very difficult because now the giant cell arteritis is causing the intracranial CNS vasculitis. And so many of these patients don't respond to standard therapy, which is tocilizumab. And so unfortunately, this patient ended up passing away from the multifocal strokes that she had. But looking back, what we could have done instead, if we had recognized this and thought about it from more of a CNS vasculitis perspective, is treating it with cyclophosphamide, which is a stronger treatment for CNS vasculitis and also has some small case series data to benefit giant cell arteritis when it causes CNS vasculitis. Of course, this is a very complicated patient, but she did have what was the right age group, had the painful headache, blurry vision, although there was some atypical forms. The most common area of involvement of GCA when it affects the brain is going to be the supraclinoid segment of the ICA, and it's often bilateral, although this is a very rare finding. And the PMR, the polymyalgia rheumatica, where she has the bilateral shoulder and arthritis involvement, was also classic for her giant cell arteritis. But ultimately, because of her CNS vasculitis disease, she didn't respond to immunosuppression on time. So I think you guys did like an amazing job thinking through all the different possibilities. And, obviously this is a very challenging case and you guys went through each symptom, each piece of the puzzle. But I really enjoyed being able to give you this, this very fascinating and unfortunately very challenging case that I learned a lot from. Yeah.
Wonderful case. And, I think it was a wonderful educational case too, because, we were able to learn so much through it. I think we talked a lot about our approach to headache. We talked about our approach to, blurry vision. We talked about red flags for headache. We talked about, deconstructing causes of optic neuropathy by location and etiology. And really we encompassed, I think we went through every single, branch, that we think about. We discussed infectious, we discussed, inflammatory, we discussed malignant, drug induced. And I think it was a wonderfully educational case. And, I would just share the cases I've had with CNS vasculitis. We have started on cyclophosphamide. Again, they didn't really, got a little bit, they didn't have new lesions. I'll say that. But clinically, they didn't massively improve from they sort of had a new baseline on discharge. But wonderful case. Vale, maybe share with us, your sort of main sort of 2 learning points.
Yeah, no, this was amazing. I think we have discussed previously like some cases of diplopia and headache, and it's never GCA, but now that we were kind of, branching out on some other different, just it was GCA. So yeah, I love it. I think I mean I have teaching points on more like the second half of the discussion that is for sure something that I'm not very educated on. You mentioned, the what are the expectations that we should have about patients with GCA, especially with this burden of disease, and that's something that I really didn't know about. So that's for sure in my English script now. And also some of like the imaging interpretation. This was really good space repetition about what Jeffrey has mentioned before about specific types of MRI that we should think for when we're thinking about vasculitis. So yeah, this was a kiki. Thank you so much. And maybe we can pass the mic to Kritika for a couple of teaching points before we wrap it up.
Thank you, Jeffrey, for the great case. And thank you, Valerie and Sebastian, for the great discussion. So today we had a patient, 81-year-old female with headache and intermittent pain and blurring of vision in the right eye. So for the headache, Valeria mentioned the causes could be primary or secondary, and that we need to look for some red flags, like in this case, we had blurring of vision. And also we need to have an anatomical approach where we decide based on the site of the origin of the headache. And what are the secondary causes which are potential emergencies are glaucoma, orbital cellulitis, optic neuritis, which could be due to any inflammatory causes, infective causes like toxoplasmosis, syphilis, Bartonella, Lyme's, or any viral causes, or it could be metabolic, or some ischemic optic neuropathy or giant cell arteritis. And also this patient had diplopia, which could be possibly due to the extraocular muscle involvement, due to thickening of the muscles in thyroid disorders or any infiltrative causes. Myasthenia could also present with intermittent blurring of vision. Cavernous sinus thrombosis due to the involvement of the cranial nerve 346 and any midbrain involvement or medial longitudinal fasciculus involvement. And Sebastian mentioned the main things to look for are the eye movements, involvement of the other cranial nerves, and fundoscopy to rule out any optic disc edema. And he also mentioned that sometimes optic neuritis could present without disc edema if the cause is more of posterior. And the other cause could be optic neuropathy, wherein there will be a central field loss and afferent pupillary defect, and there could be disc edema and disc atrophy. Considering this patient had a fever of 100 degree, so the another consideration was to rule out meningitis. So the investigations that were thought of was to look for any meningeal signs, photophobia or skin rashes with associated bacterial infection, and to get a CSF analysis, blood culture, CBC, inflammatory markers, the infectious workup and autoimmune workup. And in this patient, we had a suspicion of vasculitis, which could be secondary to the immune process like rheumatoid arthritis or Sjogren's, or due to any infective causes, or secondary to any malignancies like lymphoma. And because we suspected giant cell arteritis in this patient, it is always better to start off empirically steroids and also empirical antibiotics in case infective causes suspected.
Wonderful. Thank you so much, Kritika. That was a lovely summary of the, the many learning points of this case. I'd just like to end by saying a massive thank you to Jeffrey or Dr. Shen for bringing this case to us, and for the audience for your wonderful questions that we've been following and comments. I think it really shows the strength of our discussion, and I think that will conclude. We're at 10:10, so we've run slightly over, but thank you everyone for your engagement, your enthusiasm, and as always, your passion for learning.
Bye, everyone. Have a great day.